Before beginning any large project, such as becoming trauma-informed, it's a good idea to take stock of the current climate of an agency or facility. Who is excited? Who will help lead? Is there something that can be done to get more people on board? It's also a great opportunity to reflect back on progress that's already been made. A great thing to look at before implementation is some of the people that might not be on board or are adamantly opposed. They often will end up being the biggest advocates once it's explained and the positive outcomes of the proposed change start showing up for everyone. Who will be the leaders in this change? Leaders are not always the bosses, although bosses are necessary for the implementation. Leaders might be the ones willing to do the most work, the ones that want the change the most for personal reasons, and the ones that have everyone's ear and good relationships throughout the agency. Small-town reverends are a great example of this in the South. They can garner more support during one church service than almost anyone in town. Politicians have realized this and have started counting on non-traditional leaders to be their biggest voices. Prior to implementation, it's a good idea to brainstorm any barriers that you might encounter and begin planning for how you'll address those barriers. Also, consider how to update and inform staff throughout the agency of your implementation progress. Implementing a trauma-informed approach requires change at all levels in an organization. The Substance Abuse and Mental Health Services Administration has provided us with 10 domains identified in the literature on organizational change management. These 10 implementation domains include governance and leadership, policy, physical environment, engagement and involvement, cross-sector collaboration, screening, assessment, and treatment services, training and workforce development, progress monitoring and quality assurance, financing, and evaluation. Let's take a look at each of these 10 implementation domains individually. First, governance and leadership. This means that we have a trauma-informed approach throughout the agency, from a strategic plan to vision and mission statements. Everything in your agency's strategic plan must be trauma-informed. This is a priority from the top down. Management must all buy in for it to be agency-wide. Next, policy. All written policy must be trauma-informed. All procedures and policies within the agency are written through a trauma-informed lens, and all policy is viewed through that lens. Next domain for implementation is the physical environment. The physical environment must be physically and emotionally safe inside, outside, and in any public spaces. Consider everything that staff and clients see, smell, taste, touch, or hear, and ensure that they are trauma-informed. It's imperative that we provide quiet spaces, avoid loud noises, and avoid the smell of strong disinfectant cleaners, which can trigger an institutional trauma experience. Engagement and involvement. Group classes should be offered. Healthy relationships with peers should be encouraged, and the agency must respect how communal and relational women are. Incorporating family members into services can be a key practice for agencies implementing trauma-informed care. Cross-sector collaboration is important to consider. This means that communication between all departments and agencies is trauma-informed. Communication must be regular and open. This requires that all departments receive the same training to be trauma-informed. Similar practices must be observed by all agencies. Imagine a scenario where a courtroom is completely trauma-informed until an unsuspecting probation officer with no knowledge of trauma-informed services enters the room. One individual being out of sync with the rest of the agencies can derail trauma-informed practices. Policies written throughout the agency must be consistent. Screening, assessment, and treatment services are also important. It's necessary that these practices be gender-specific and trauma-informed. When utilizing assessments, screenings, and treatment services, staff need to utilize trauma-informed communications. There are many gender-specific assessments and practices available to support you. The Gender-Informed Needs Assessment, the Women's Risk Needs Assessment, and case management tools such as Pathways to Change. These tools all utilize a gender-responsive approach as well as a trauma-informed approach. Training and workforce development is also important. Training should be provided to all staff in all departments, and staff need to remain up to date on all training. It's important to note that repetition of training information is important for retention and understanding. Staff must be trained on self-care and secondary trauma. If staff understand and buy into the importance of being trauma-informed, it will pay dividends across your organization. Progress monitoring and quality assurance requires ongoing assessment, tracking, and monitoring of trauma-informed principles and the effective use of trauma-specific screening, assessments, and treatments. Clients should be afforded trauma-informed groups, and these groups should be provided at scheduled and consistent times. Intermediate results of trauma-informed groups should be evaluated, rather than waiting until the group is completely over. Quality assurance practices should be done on all programs and services within the organization. An organization's priorities can often be determined by examining their budget. Finances must be devoted specifically for trauma-informed training, programs, services, and practices. Evaluation efforts should also be done to demonstrate the effectiveness or ineffectiveness of trauma-informed practices. Recidivism rates should be going down. Drug use and self-harm should also be decreasing. The agency should be measuring these outcomes to make sure that their trauma-informed approaches are working and are utilizing the best evidence-based practices available.